Today we are discussing anti-GBM antibody disease. Anti-GBM antibody disease is characterized by renal or pulmonary small vessel vasculitis, and it's usually caused by anti-GBM antibodies only. Yeah. So there is no other definition for this. So you can have two system involvement, renal and pulmonary. Pulmonary may or may not be there. Patient can have non-specific symptoms for a few weeks, maybe months. Patient can present with a rapidly progressive glomerulonephritis or acute kidney injury, pulmonary hemorrhage, or subclinical lung involvement. So coming to the organ involvement in anti-GBM disease, there are three entities of anti-GBM disease, namely Goodpasture syndrome, where you have both renal and pulmonary involvement, anti-GBM glomerulonephritis, when there is only renal involvement and lungs are not involved, anti-GBM pulmonary hemorrhage or alveolar hemorrhage when you have only pulmonary involvement. So this is a small vessel vasculitis which involves the glomerular and pulmonary capillaries, which is caused by circulating anti-glomerular basement membrane antibodies. So crescentic glomerulonephritis. To tell as a crescentic glomerulonephritis, you need more than 50% crescents in a renal biopsy. So anti-GBM disease is a single hit disease. So you have monomorphic crescents, whereas in ANCA-associated vasculitis and immune complex-mediated glomerulonephritis, you can find pleomorphic, and ANCA it is usually a pleomorphic crescent. And necrotizing lesions may be there in anti-GBM, but mostly in ANCA-associated glomerulonephritis. There is a peripheral linear IgG positivity in immunofluorescence, as Nainans just mentioned, in anti-GBM disease, which is a strong positive one, whereas immune complex deposits are seen in immune-mediated GN, and in ANCA there can be a less than 2% staining for IgGs. And electron-dense deposits are seen in immune complex glomerulonephritis. Clinical presentation of anti-GBM disease. Anti-GBM disease is very rare. 15% of all crescentic glomerulonephritis is anti-GBM disease. It has a bimodal age of onset, third decade and sixth decade. There are a few major clinical presentations which involve the renal and pulmonary syndrome, rapidly progressive glomerulonephritis. Almost all cases you have hematuria, and proteinuria is common. There are certain predisposing factors for anti-GBM disease, which include medications, cigarette smoking, hydrocarbon use, and genetic factors. Coming to the pathogenesis of anti-GBM disease, anti-GBM disease, there is binding of IgG antibodies to the glomerular basement membrane. The complement-mediated pathway, classical pathway, is activated. There is recruitment of neutrophils. These neutrophils degranulate and netosis is there, enzymatic degradation of the glomerular basement membrane, and there is a bleeding into the Bowman space. Then there are certain coagulation, fibrin, macrophage infiltration, cell proliferation, crescents, and other mechanisms of T-cell injuries are also postulated. Coming to the pathophysiology, type 4 collagen is made of 6 alpha chains. Alpha 3, 4, 5 protomere is involved among these. This hexamer with cryptic EA and EB epitopes are seen as shown here. Normally these epitopes are hidden inside the collagenous structure of the alveoli and the GBM, which is held together by disulfide bonds across the NC1 domains. This is the disulfide bond. And several factors such as smoking, hydrocarbon exposure, infections, flu, COVID-19, renal involvement with membranous nephropathy, ANCA-associated vasculitis, they are all environmental factors which cause disruption of this hexamer and exposure of hidden antigens. In patients with genetic disposition also, this process may lead to development of anti-GBM autoantibodies. And there is production of anti-GBM antibodies. So as you can see in the left side, the IgG1 and IgG3 subtypes are directed against the epitope EA and EB of non-collagenous domain of alpha-3 genotype 4 collagen of the GBM. This phenomenon leads to the recruitment of different inflammatory cells in the capillary roots of the glomerular trough, causing the disruption of GBM and capillary wall and extravasation of different cell types with the formation of crescents. Now we have a clinical case scenario. A 60-year-old male presented with AKI and fever since 7 to 8 days. He's hypertensive and obese. He had a serum creatinine of 11.1 milligram per deciliter. His UPCR was 0.91. His urine routine examination revealed RBCs 50 to 60 per high power field and albumin trace. So this was his kidney biopsy, which shows a large cellular crescent. The Bowman's capsule is destroyed. It is not visible. The crescent has replaced it, giving it a starburst appearance. In this picture, you can see the glomerular trough and you can see the crescents in this picture, which is cellular. In the tubules and interstitium, you find some amount of tubulo-interstitial injury and interstitial edema. And in the staining, again, you can see the crescents in the image with the this underlying tuft, and there is a remnant of Bowman's capsule in this silver stain, and the remaining Bowman's capsule is destroyed by the crescent. Here you can find the crescent with a multinuclear giant cell reaction to it, and here you can find few eosinophils also. So crescent with giant cell reaction with eosinophils. And IF clinches the diagnosis with strong positivity for IgG staining, which is a peripheral linear IgG staining. C3 is 1 plus positive, and there is kappa and lambda restriction. The serology is performed by ELISA, and it was a negative. A negative serology with a positive direct immunofluorescence is something that we see commonly in anti-GBM disease. And what are the factors which cause this serology negative but immunofluorescence positive? There can be false negatives. It can be due to low titers or transient production of antibodies. Epitopes other than EA or EB, other subclasses such as IgG4 or alpha-4-5 may be involved, and in atypical anti-GBM disease, which I will come into the subsequent slide. And when a line immunoassay was performed, the anti-GBM was strongly positive. So standard ELISA testing is positive in 87% for anti-GBM, but it is negative in 13%. So what is this atypical anti-GBM disease? A typical anti-GBM disease accounts for 10% of the cases, and it is a slowly progressive glomerulonephritis, and it is also characterized by hematuria and heavy proteinuria usually. In typical anti-GBM, sometimes there can be only a mild proteinuria. Lung involvement is absent in atypical anti-GBM disease, and serology is negative. And light microscopy shows crescents which are less than 50%, endocapillary, mesangial, or membranoproliferative, plus or minus a thrombotic microangiopathy can be also seen. The prognosis is good in atypical anti-GBM disease. So this slide depicts the difference between a typical and atypical anti-GBM disease. Now we have a Mayo classification for this is a Mayo group has put forward. Most common, this is clinical pathological characteristics and outcomes of atypical anti-GBM nephritis in 2016 they have published. The most common finding in light microscopy is endocapillary proliferation, as you can see. And most common immunofluorescence finding is IgG1 and IgG2. And in typical anti-GBM disease, however, you find the most common finding is IgG3 followed by IgG1 in a typical anti-GBM disease. So what are the differentials of linear IgG staining on direct immunofluorescence? You can have a monoclonal immunoglobulin deposition disease, MIDD, with light chains having affinity for GBM components. In diabetic glomerulopathy, you can have a GBM thickening and loss of negative charge. So these are other differences of linear IgG staining other than anti-GBM disease. Other disease associations with this IgG staining is an ANCA-associated post-immune glomerulonephritis, membranous nephropathy, and IgA nephropathy. In monoclonal immunoglobulin deposition disease, there is staining of entire tissue of this glomerular basement membrane, tubular basement membrane, and Bowman's capsule. Whereas in diabetic kidney disease, you have a IgG linear staining, but it is usually a duller staining. Coming to dual antibody positive, that is dual ANCA and anti-GBM positivity, that is seen in about 1/4 to 1/3 of anti-GBM patients have ANCA, and that is usually an APO, anti-neutrophilic cytoplasmic antibody. And most patients have renal limited disease, and some have GPA or eosinophilic granulomatosis polyangiitis. They clinically resemble anti-GBM at presentation, and in light microscopy, you find crescents with variable chronicity. Immunofluorescence will show linear IgG staining, and severity is according to the histology, that is anti-GBM or anti-GBM or plus or minus ANCA or ANCA. So the histological severity increases. The higher rate of relapse is seen when anti-GBM is associated with ANCA. Anti-GBM as such, the relapse rate is not that frequent. Treatment of anti-GBM disease revolves around pulse dose of corticosteroids, cyclophosphamide, plasma exchange, and supportive care as needed with dialysis, and in pulmonary alveolar hemorrhage, sometimes mechanical ventilation. So coming to the treatment strategy in anti-GBM disease, the KDIGO put forward the following recommendations, which I'll be dealing in subsequent slides. KDIGO recommends initiating immunosuppression with cyclophosphamide and corticosteroid, along with plasmapheresis in all patients with anti-GBM glomerulonephritis, except those who are dialysis dependent at presentation, who have 100% crescents in an adequate biopsy sample and do not have pulmonary hemorrhage. And observational studies have shown that early mortality of anti-GBM has decreased from 47% to 8.5% with plasma exchange and immunosuppression. And 5-year patient survival is currently over 90% with treatment. Treatment should be started as early as possible, and recovery of kidney function is only 5% in patients who have high proportion of crescents, about 85 to 100% on kidney biopsy, oliguria, or advanced kidney failure requiring initiation of dialysis. In such patient, decision to initiate therapy should be taken into account this low chance of kidney recovery, and treatment is necessary in those who have pulmonary hemorrhage. Start without delay even before the diagnosis is confirmed. Plasma exchange should be performed until anti-GBM titers are no longer detectable. Cyclophosphamide should be given for 2 to 3 months and corticosteroids to about 6 months. And this is the algorithm for the management of rapidly progressive glomerulonephritis when there is a alveolar hemorrhage and when there is alveolar hemorrhage which is absent. If there is a alveolar hemorrhage in HRCT at presentation, send serology for anti-GBM antibodies, send ANCA, ANA, and for the young patient, you exclude infection at presentation or within 24 hours, obtain a kidney biopsy, including IF if possible. And if data is back within 24 hours, you treat with steroids, plasma exchange, and cyclophosphamide. If data is not, then also you have to treat with steroids and plasma exchange until data back confirming a diagnosis of anti-GBM disease, and monitor the renal function, pulmonary infiltrates, and modify the treatment accordingly. If alveolar hemorrhage is absent, then again you need to look for anti-GBM antibodies associated ANCA and also ANA, other autoimmune diseases. If alveolar hemorrhage is absent, consider conservative approach in patients without alveolar hemorrhage who are oligoanuric or who have advanced kidney failure requiring dialysis, especially if they have a very high proportion of presence, about 85 to 100% on kidney biopsy, then you can consider conservative approach. Treatment: plasma exchange, 40 to 50 ml per kg, ideal body weight exchange daily with 5% albumin. If there is a pulmonary hemorrhage, FFP will be the replacement fluid. Oral cyclophosphamide 2 to 3 milligram per kg. Give it for 2 to 3 months. Cyclophosphamide dosing should be reduced in case of leukopenia. Steroids initially up to 1 gram per day on 3 consecutive days, and you have to give for 6 months. And thereafter, you reduce the dose of steroids to 20 milligram per day by 6 weeks and continue for 6 months by tapering dose. Now, factors which are favoring aggressive treatment are when the patient is having pulmonary hemorrhage, when the patient is having good urine output, serum creatinine is less than 5.5 milligram per deciliter, and even if the creatinine is more than 5.5, but the patient is having rapid recent progression with ANCA positivity, and if the glomerular damage is less severe, and if the crescents are recent, and you have only cellular crescents, and if early transplantation is desired by the patient, then you have to go aggressively. And if the associated disease is absent, then also you have to treat the patient aggressively. And factors against aggressive treatment are when a pulmonary hemorrhage is absent, and there is oliguria, anuria, creatinine more than 5.5, associated disease like which is unusually high risk from immunosuppression. So maintenance therapy is usually not required. Relapses are uncommon, and you should discourage smoking. Patients with glomerulonephritis who are anti-GBM and ANCA positivity, such cases has to be treated with maintenance therapy as like in ANCA associated vasculitis. Up to 1/3 of the patients with anti-GBM are ANCA positive, and there is a greater chance of kidney recovery from dialysis dependence than patients with only anti-GBM antibodies in double positive cases who are having lung hemorrhage at presentation. In refractory anti-GBM disease, rituximab may be tried. Refractory anti-GBM disease is rare, less than 10%. Experience is limited with rituximab, and it is restricted to few case reports and few small case series. And there are several case reports of patients with anti-GBM disease successfully treated with mycophenolate instead of cyclophosphamide also. But as of now, rituximab, infliximab, rituximab and other rituximab is only an adjunct. Imlifidase is another treatment which is in the phase 3 trial in 2025. It's an IgG degrading endopeptidase from Streptococcus pyogenes that cleaves human IgG into FAB2 and FC fragments. And immune adsorption removes anti-GBM antibody effectively. Among 10 patients with anti-GBM treated with immunoadsorption, dialysis dependency was successfully reversed in 3 out of 6. So what is imlifidase? It is an endopeptidase selective for IgG. It binds to FC part and cleaves IgG at glycine 237. One FAB2 fragment and one FC fragment is there. It was discovered in 2001 by Lars and Lund, and it was developed into a drug by Hansa Biopharma. And it was licensed for enabling transplantation in HLA immunized patients. The rationale for treating anti-GBM disease with imlifidase, like you can know, this is an untreated case of anti-GBM disease where the anti-GBM antibodies go like this. The day 0, as you start imlifidase, the anti-GBM antibody titers, you have a drastic decrease in the anti-GBM titers, which is seen very fast. within 24 hours. Whereas in PLEX, the anti-GBM antibody titers, about 60% are removed on the first day. Again, from the extravascular space, the IgG comes again into the intravascular space. Then you have a peak. Then again, with subsequent PLEX sessions, the anti-GBM antibodies come down. So imlifidase is promising in this slide, but as of now, it is still to be considered as an adjunct. Kidney transplantation in patients with kidney failure due to anti-GBM disease should be postponed until anti-GBM antibodies remain undetectable for at least 6 months. Recurrence of anti-GBM disease will be 50% after transplant in patients who already have an anti-GBM at the time of transplantation. Nowadays, with good treatment, it is very rare and less than 3% in patients who have no antibodies. Anti-GBM antibodies form in 5 to 10% of the patients with Alport syndrome after kidney transplant, but overt anti-GBM disease is less frequent. And if clinical anti-GBM glomerulonephritis occurs, it often does so early and results in a graft loss. So in post-transplant, how is anti-GBM? It rarely occurs. It occurs in about 3 to 5% of the patients with Alport syndrome post-transplant due to alloantibodies against GBM antigens that are lacking in Alport patients. It is seen. The clinical presentation is same as a new onset disease and serology is positive. Epitope specificity in Alport patients is different from that of autoantibodies in recurrent disease, alpha-5 and C1, because in anti-GBM, the ELISA detects the alpha-3. So sometimes the epitope specificity is important, and you need to keep this suspicion of anti-GBM very high. Patients who have lost a graft to anti-GBM disease are at a higher risk of recurrence. So the disease course and prognosis of anti-GBM. Anti-GBM is an aggressive disease and it is worse than an immune complex mediated on the post-immune glomerulonephritis and requires an intense therapy, and it should be as soon as possible and one major episode rather than a relapsing remitting course. So it is a single hit. It cannot be transplanted. We cannot do a transplant in the presence of circulating antibodies. You need to wait for at least 6 months. Major predictors of outcome are the severity of renal injury and serum creatinine. So this is the latest publication in NDT, antiglomerular basement membrane disease, the treatment standard, which has been published in 2026 in NDT, which I will be sharing at 10 p.m. in our extracorporeal nephrology group, which emphasizes the treatment standard. With this, I will close today's talk. Thank you.